A warm welcome to Medical Skills, the provider of medical education for more than 5 years to such people as the Royal Society of Medicine, the Royal College of GPs and many other people worldwide. We would like to share with you now our suite of training videos that we've developed with our team of healthcare professionals and our partner, Disposable Medical Instruments. They cover most of the core competencies needed for minor surgical training for general practitioners and other healthcare professionals. When you first receive your pad, there is no lesion. So, start by drawing a 4mm lesion on one corner of the skin pad. Use the ruler provided with the marker pen and with a light touch, gently outline the edge of the lesion. As we have said, the normal excision margins for a benign lesion are 2mm. So, with the ruler, carefully measure a 2mm margin around this lesion. In this practical, we are doing a 3:1 ellipse, so therefore measure the diameter of the completed marked up lesion and measure this either side to create a lesion that is marked 3 times as long as it is wide. Complete the marking by converting this into an ellipse, carefully touching the sides of the original margin with the sides of the ellipse. When presented with a lesion in real life, it is important to define the edges of the lesion and then, with a ruler, mark a 2mm margin outside the edge of the lesion. Once you have marked your ellipse, it's important to orientate yourself in the lines of relaxed skin tension. This is done by gently pinching the skin to see where the folds of the skin demonstrate the lines of a relaxed skin tension. You will then put your ellipse along the longitude of that line. After marking your lesion, the use of a field block of local anaesthesia uses as few needle punches as possible. Once again, starting at one end of the ellipse, you advance the needle as far as you can down the ellipse and inject whilst gently withdrawing. Without coming at the end of the ellipse, advance down the other side and repeat the same procedure. Swapping sides, repeat the same procedure again. This is ideal for lesions where direct infiltration is not desirable, such as abscesses, cysts or lipomata, or for much larger lesions. Having marked out the ellipse using the 3:1 ratio and having infiltrated with the appropriate local anaesthetic, you can begin to excise your lesion. Using firm downward pressure and with the curved section of the scalpel blade, cut from one end of the ellipse to the other with one fluid sweep. You should aim to cut through the whole depth of the dermis, so subcutaneous fat is visible as the scalpel moves along the line you have drawn on the skin. It is important, during the excision, to always hold the scalpel at 90 degrees to the skin to prevent shelving of the walls of the excision. Having cut out one half of the ellipse, ideally in one go, repeat this on the other side so that you've incised through the skin down to the fat around the whole outline of the ellipse. Avoid taking multiple sweeps through the skin, as this leaves uneven dermal edges and can again complicate wound closure and subsequently delay healing. Once you've removed your ellipse, it's very important to check that there is a cuff of fat uniformly on the base of the ellipse to to ensure full layer thickness removal.